Sounds good. All right, you guys be patient with me. If it takes me a minute to remember these folks, it's been a busy couple of weeks around here. So this first patient is a 53, is actually a 50, oh, he is 53. I'm on the wrong patient. Thank you, Jenna. Jenna, chime in and correct me if I need corrected, okay? So this is a 53-year-old male, has a history of IV drug use and has kind of come a long way since then. That was a lifetime ago, according to him. He, I believe, got off of drugs with like an NA program, and he does have hepatitis C. He has a history of cirrhosis as well. He's actually had a TIPS procedure before, and he was treated for hepatitis C in the past. And I think, let's see, he was on pegylated interferon at that time. He can't remember exactly how long ago it was. I want to say it was 10 or 15 years ago, but it was a long time ago, and he got the TIPS procedure. He really hasn't been following up with hepatology or GI or really even primary care very consistently since then. And he hasn't had any problems. He also drank heavily in the past. I think that's part of what contributed to his liver issues. So we've removed some insults, and he seems to have done a little better. So if you want to start going down through his labs, he does have, I will say before we start on his medical stuff, he has United Healthcare as his insurance. So kind of moving down through his labs, I'm going to pull up on my side as you go through those just so I can be more familiar with it. His CBC was pretty much normal. His CMP, his sugar was a little high. He is a diabetic. His AST and ALT were both high. His AST was 106, his ALT was 94. His albumin was just a tiny bit low. Otherwise, that looked okay. If you look at his direct bilirubin, it was a little bit elevated, 0.5. His iron was a little elevated, and his ferritin, which is not up there yet, but his ferritin was 856. So that was pretty elevated, which I know we see in cirrhosis. Of course, also see with some alcohol. He is not drinking currently, according to his history. Vitamin D was a little bit low, so we have replaced that. His AFP was okay, HIV was fine, his genotype is 1A, and his viral loads almost 500,000. So is that all? I think. Anything to add, Jenna?
No, I think he's pretty compliant. That's one thing that I can say about him. I think that he'll actually do what we tell him to do.
Mm-hmm. So I guess our only question is there any change because he was treated in the past with the interferon, or is the treatment pretty much the same?
Thank you, Dr. Bailey. So were there any comments, questions, recommendations to Dr. Bailey's question to the case?
Hey, Dr. Bailey, this is Kaylee. I'll let the spoke if anybody has any comments first, and then if not, I'll jump in. But I'll give the spoke an opportunity if you guys want to go ahead and give your input first.
Joanna, how high was his iron, did you say?
His ferritin was 856. His iron was 121. His iron saturation was only 40, though.
Joanna, how long ago was his TIPS procedure?
It's been over 5 years. He couldn't tell us an exact date, but it's been over 5 years. Probably between 5 and 10 years.
Hey, Joanna, do you have any recent imaging on him?
We got an ultrasound on here, I think. No, we did not do an ultrasound on him. We don't have a CT scan or anything like that.
Okay. How about an AFP? Do you have any like recent alpha theta protein?
Yes, that was normal.
Okay, sorry, it might be on here. I just didn't see it. Okay. So I guess a couple thoughts whenever you were presenting his case that came to my mind. The first thing I'll address in terms of, you asked about treatment since he's had interferon exposure. It depends. So if he completed interferon treatment and, you know, even if he doesn't know how long ago it was, because a lot of patients don't remember that part, but I ask if did they finish the full course? Was it stopped because of side effects? So if he had 2 rounds or 2 doses of interferon and then, you know, had side effects and they had to discontinue it, I wouldn't necessarily call him a treatment failure. It was discontinued because of adverse effects. Now, if he finished treatment or on treatment, his viral load didn't change at all, I would consider him treatment experienced and a treatment failure. If you can't get that information, then I err on the side of going ahead and treating him as treatment experienced, which does change your management a little bit in terms of duration and some of the options. So that would be one question I'd ask him. The other thing is to, you know, really making sure you have a really good assessment of his liver stability. So, you know, I would certainly get an updated ultrasound on him, particularly as an HCC screen. But also, you know, I tried to calculate his FIB4. You know, I know we know he's cirrhotic, but I'd go ahead and calculate his child Turcot's and his MELD scores as well, just to make sure, you know, he's meeting criteria that's safe for us to treat him and not needing to be managed by a hepatologist. And that in line with clinical signs and symptoms of decompensation too. So, you know, even after TIPS, if he's really stable, you know, you could treat him and follow him closely, but I would be really cautious to do that in a primary setting without a really good understanding of if his disease is stable enough. The other thing is, you know, I know he says he's not drinking, but the other thing that stuck out at me was his, you know, his transaminases, his AST and ALT are both elevated. His AST is a little bit higher. Now we tend to think, okay, this is more alcohol related if it's a ratio greater than 2, which his isn't. It might be that pattern is simply because he has cirrhosis and he has Hep C. I also would consider in him as well fatty liver component. He's got metabolic disorder, and so I think, you know, he's somebody that has multiple liver insults, and so I'd really make sure, you know, the alcohol is harped with him too, and he takes that seriously as well, or his outcomes are ultimately going to be the same whether or not you treat his hepatitis. His treatment options, so you basically still have the same 4, the Mavorite, Epclusa, Zepatier, Harvoni. Now, Harvoni in the setting of cirrhosis with treatment experience with PEG interferon is actually 12 weeks plus weight-based ribavirin. And that's the alternative regimen. So I don't tend to go with that one. I tend to, because he's had decompensation in the past, try to avoid PI agents. So I really wouldn't use Mavorite in his instance either, or Zepatier. So I would feel most confident with Epclusa for 12 weeks in this gentleman. But, you know, I also would still just make sure he really got a good understanding that his liver disease is stable. If he's a child's Turcot B, you know, or his MELD is over 9, I wouldn't mess with trying to treat him. I would have hepatology evaluate him first and kind of guide that assessment with. Yeah.
Okay. Okay.
And I saw you had chatted in. Did you have a question as well?
Sorry, I was just checking something. I don't know if Dr. Bailey, if you mentioned after his treatment with the pegylated interferon, did he say he had not had any risks for re-exposure? Or we just don't know if he was cleared the last time?
That is a really great question. I am not totally sure. I want to say that he has not had any risks for re-exposure, but we can confirm that. I think he, once he kind of got off of drugs, he's, pretty much stayed that way and didn't really get a lot of healthcare until after he had already kind of gotten away from drugs.
And I guess the reason I asked, and Kaylee or Dr. Gilfus confirm if I'm wrong, but I guess, does it make a difference then if he had a re-exposure possibility, then that he would be, that he failed treatment?
Great question. So yes, so if he had successfully achieved SVR and this was a new infection, then you would treat him as naive. Unfortunately, it's hard to get that information a lot of times unless you can really get clear prior record he was following and cared consistently. It's difficult to sort that out. Sometimes if you can get old records and the genotype's different, but a lot of times, even if they're reinfected, it's going to be genotype 1 again. And so, if you're able to get that information, then yes, that would play a role. Now, in his case, because he's cirrhotic, his treatment management options would be generally the same. I'd still go with Epclusa for 12 weeks. And because of his history of decompensation and his advanced liver disease, I still wouldn't go with a PI agent as my preference. So I don't think, overall, is it going to change his treatment options? In his case, no, but that's a really good question because yes, it can play a role. I wouldn't, if it was a reinfection, you don't consider them experienced with treatment.
So for instance, like if you had, so I have a lady now that had to stop pegylated interferon because she went to prison years ago. And so she was kind of discontinued during her she didn't have to stop because of side effect. Like you still wouldn't consider her treatment naive though. Is that true?
How much, do you know how much treatment she got?
It was a few months. She honestly, she doesn't really remember quite as much. She said it was about 2 or 3 months worth of treatment. That was one of the things I was trying to struggle with. Do you consider her naive, or do you consider her, like, would she be 8 weeks of Mavreat, or would she be, like 12 weeks of Epclusa? Like, and I don't really know what to do with her.
Unfortunately, there's not good guidance as to how to approach a discontinuation because there was a treatment interruption. I just don't, there's not data that says how do you, even with our DAAs, if you have a treatment interruption, then do you have to start a new agent or can you just finish that course or whatnot? My practice is if they just got a brief exposure to interferon and it was stopped because of something like that, I still would consider them treatment naive. But if they got a few months or they didn't have any change in their viremia while they were on interferon, then I'd go ahead and just err on the side of I'll treat them as experienced. I'd rather be overcautious with my management than undertreat. And Dr. Gilford, because I don't have the experience with interferon agents that he does, so I don't know what his approach tends to be, but that's my approach.
Hey, can you guys hear me now? Unmuted. Yeah. It's John at the Hub, Gilfus. I just wanted to start off by saying 100% agree. Kaylee made great points. The only treatment option in my mind is Epclusa. You obviously want to avoid any protease inhibitors in this guy. But Joanna, one of the things, I'm always amazed. I mean, how many patients have we presented with Hep C for echo? It's got to be, I don't know, it's a lot. And I don't think we've ever had one with TIPS procedure that I can recollect. And in particular with the TIPS, I think delving into the why he got the TIPS is huge. And if he got TIPS because he had varices and this was preventative, that he would probably be a little bit lower risk. If he got TIPS because he had ascites, this is a guy that you want to co-manage, like Kaylee was saying, with hepatology, because he's a decon, like no ifs, ands, or buts. And I would basically only treat this guy on your own if he's unwilling to work with a hepatologist. In other words, if he's like, oh, the hell with it, I'm not going to go see a specialist, I'd rather die here at home, then you can treat him. But if you're going to go buy the books from this guy, if he got a TIPS because and was a decompensated cirrhotic, we'd be going against every tenet that we preach here in the ECHO program, and that's, we don't want to treat decompensated patients without a hepatology assistance. But that being said, if he says no, I don't want to be treated, he'll do okay with Epclusa. He'll do fine. But I would just go into that concept of why he got the TIPS. The only other thing I was going to mention is TIPS and encephalopathy. And I don't know if if he has any degree of encephalopathy, and if that would at all impact our adherence capabilities, but hopefully not. Hopefully, again, I don't think we've ever had a TIPS patient. In my mind, it matters why he got it.
It was ascites. He had massive ascites.
Yeah, this is probably a guy, if he's willing, that, like Kaylee was saying, you want to co-manage with a hepatologist. But at least from the antiviral standpoint, Kaylee walked us through it perfectly. You want to avoid Harvoni because you'd have to add ribavirin on probably, and you don't really want to do that to somebody. In terms of Greg's question, how much qualifies as treatment exposure? I don't know. Like Kaylee said, I have no idea. Just a general thought process is, in general, I think they're trying to hint at, if you are a prior treatment failure, you're going to be somebody who's harder to treat. And that's, in general, I consider prior treatment failure to be completing an entire course. So a 48-week course of PEG interferon with ribavirin. So anything less than that, I just consider treatment interruption. So
this is Kaylee, and I want to make another comment. When we talk about compensated and decompensated, just remember this is a spectrum. So you can be compensated for a long period, have a decompensating event, adjust those factors that contributed to that, get managed, get that, the ascites under control with diuretics, get a TIPS, have the encephalopathy managed. And so you can even still be managed successfully to a degree of compensation, even with prior decompensating events. And so, even if he had ascites in the past, got a TIPS, has been stable since then, he's not necessarily still decompensated. It's just really making sure we have that assessment and have that judgment before we tend to treat him. Because to be honest, I know we want him, he should be following with a hepatologist. There's one in the state of West Virginia. So that adds a huge, and I always want to get Jean back in here because she's our hepatology expert, but her and Dr. Hudson are two experts in that field. And so their assessment is really key for us. And so, you could try to refer him to a local GI, but they may or may not even feel comfortable with his hepatology management. So he's somebody that, we may want to just bring her on board too, but I would calculate your MELD and your child's PEW because, that also factors in if they've had a TIPS in the past. And so, just to kind of get an idea of what's his stability at this point in time.
Okay, I went ahead and did his MELD. His MELD was 8, his child Pew depends on what I do for ascites. So his child Pew depends on if I say he has slight ascites, which is probably true. It's 7 and he's class B, but he's had tips, so
Sure.
you know.
Well,
I think
and
he's going to be class B either way.
And I think too, you know, also getting an ultrasound on him too, you should be able to see if there's any ascites and what degree. But I think as a safe bet, you know, if he's child's B, I would make sure you have the blessing of liver. Yeah, and he may even be something that we can try to run by Jean and get her recommendations. And honestly, we're doing video visits up here now, so she may even be able to see him through a virtual means if it's difficult for him to get in. I don't know if any hepatologists your area or really anywhere. So
no, about 4 hours away is the closest. So if we could, maybe Jenna, we could set up like a telehealth with her and him here, and we could discuss with her and come up with a plan that way.
I can send her a message and just ask how they're doing their telehealth right now. But yeah, I think to at least get some involvement in her assessment would be of value. But good case. Thank you.
Okay.
We don't talk about that at all, really.
Yeah.
Even treatment experience, we don't see too many of.
That's very true. That's very
Cool.
true.
Thank you.
Thanks, guys, for that awesome discussion and recommendations. Dr. Bailey, we are about halfway through the session time. I wanted to ask you, do you want to go through doing the on-demand for your second case, or did you want to save it for next time? I don't, if it's an urgent case, of course, I don't want to put that aside. So
Sure.
it's totally up to you.
He's pretty straightforward. If we want to just do
Sure.
on-demand, that would be fine.
On demand. Okay, sounds good. Awesome. Well, thank you guys so much for that awesome case. So we have Dr. Cooper for the didactic portion. I can pull up your PowerPoint for you and just let me know when you'd like me to go to the next slide.
Okay, that'll be fine. All right, so as I had mentioned before, my name is Garrett Cooper. I'm an infectious disease doctor here at WVU, but I also have a different role. It's a little different than a typical infectious disease consultant in the sense that I provide primary care for patients who require long-term antibiotics at the hospital. And what that means is that you guys may have heard, but West Virginia has a bit of a substance use issue. So a lot of patients who come in with things like endocarditis, osteomyelitis, serious infections, life-threatening infections that require long-term antibiotics, they're not going anywhere anytime soon. So they typically stay in-house for 4, 6, sometimes 8 weeks, and I manage their antibiotics. While I was doing my training, my expert tutelage under John Gilfus and with Kaylee Berner as well, it occurred to me that there was a giant issue in the sense that infectious disease, you know, we always talk about source control being the biggest thing. And it occurred to me very early on that source control for this population is treating their underlying substance use disorder. So the reason why this is pertinent is that a lot of the patients that you see, have seen, or will see, probably the vast majority, 9 out of 10, maybe 95 out of 100, are going to have some history of substance use. And I'm going to take a wild stab and say that you probably have varying experiences as well as a comfort level in terms of dealing with this population, how to address their underlying substance use, what other things you need to be worried about because of their history of substance use. And that's kind of what we're going to talk about today. So we can go ahead and go to the next slide. And these are just quickly the goals. Again, recognizing how the population has changed from when I was being trained, from when a lot of us were being trained, to what it is now, how addiction plays a role in all of this, some ways that I approach this population specifically, and then the idea of comprehensive treatment, not just the hepatitis C, not just the substance use, but some of the other things that kind of come part and parcel with patients that have a history of use. So the next slide, please. So just to jump right in, the population, what kind of patients do we see these days? Next slide. So this is split up into two parts here. On the left here, this is what it was back in 2010. So again, this was for those of us who were trained earlier. We would typically see this in the baby boomer population. There was the recommendations a couple years ago that anybody that was a baby boomer should be tested at least once. Patients before 87 who had clotting factors that they were given, any transfusion or transplant patients before 92, patients on hemodialysis, HIV infection, co-infection is also an important one, transmission through mothers, or healthcare workers who might have been stuck. So it was a pretty, not a very large group, but certain risk factors that we all had to be aware of. But on the next slide. So this is what's happened in the last 10 years, is that you can see there's been a big old jump. And this is data actually from the West Virginia Health Department. And it's showing how the acute hepatitis C infections are bumping up in West Virginia, which is why we're all here. We're seeing this more and more out in rural areas, underserved areas. And that has been very directly associated, correlated with injection drug use. So next slide. Now this is from the national database, but it does reflect, I think, well on the state of West Virginia. And this is looking at what do we know about the cause of hepatitis C? And this was from a couple years ago. This was the most recent data I could find. But you can see by and large, the largest is from injection drug use. So people who have a history, can anybody else still see that? Because I can no longer see the PowerPoint.
We can still see it.
Okay, I cannot. I don't know what happened to it.
We did get a chat in. It might be a chat box that popped up and maybe opened up a new window on your end.
Maybe.
Let me see. Are you able to see it now?
Nope. I don't know why.
I could stop sharing and reshare if you'd like. We can give that a shot.
Okay.
All right. Are you able to see that?
Yeah, I can see that now.
Awesome.
Sorry for that, everybody. I'm not sure what happened on my end. But anyway, to quickly wrap up that slide, it is showing, and Kaylee just sent in another message. I think it is the chat message that is screwing it up for me. So to quickly go through that slide, it is basically showing that, again, the injection drug use is the biggest one, and then risky behaviors, multiple sex partners is another big one. Next slide. So how do we get from substance use disorder to hepatitis C? It's a pretty common thread that I see with my patients, that not everybody jumps straight to intranasal or intravenous drug abuse, but it typically starts with prescription opioids. They're the most commonly, especially here in West Virginia. And about 1 in 10 to 1 in 5 of that population will then escalate to injection. And that is how you see this hepatitis C infection also occurring. And then we can see that, as we know here in Appalachia, West Virginia, as well as along the Mississippi River, that in the past 10, 15 years, that has been the biggest case incidence of increase of hepatitis C in the United States. Next slide, please. So what makes West Virginia particularly vulnerable for this to happen? It's a question I've asked quite a bit. I don't know if you've ever thought about it yourself, but it's kind of a triad of things that we all see in our typical population. And again, this is not being derogatory. This is just looking at, the typical patients we see. And then one, in West Virginia, with the mines shutting down, if you're up in the northern panhandle, steel mills, but a lot of the typical job opportunities are gone. So you see a high level of unemployment and poverty within the population. At the same level, because you could get a job, 30 years ago with a high school education and you didn't need further training, you didn't need any secondary education, or tertiary education, I should say. So there wasn't a lot of education about some of the opportunities and risks. And then finally, poor life expectancy. I think we've all seen data about how the working class within Appalachia has a much higher risk of morbidity, mortality, especially recently. So between these three things, it kind of puts this population at risk for drug misuse and eventually culminating in hepatitis C infection. Next slide, please. So addiction, how does addiction play into all this, and why should that be a factor to think about when you're talking about hepatitis C treatment in this population? Next slide, please. So addiction, the big thing I want you to take out of this slide, other than that nifty picture that I was able to find, was that it is a chronic disorder and it's relapsing. So one of the things that you probably have a conversation with about your patients who have a history of drug misuse is that, you know, are they clean? How long have they been sober? I know that's often a indication for insurance, whether or not they can receive therapy. Whether it's 3 months, 6 months sobriety, what have you. But addiction, it's a chronic thing. It doesn't go away. The way that I think about it is kind of like with alcoholism. I think we all kind of understand that for an alcoholic is always an alcoholic. It's just whether or not they're actively drinking. And substance use, any substance use, is no different. The other thing to consider that it is relapsing. People have issues where things come up in life. I like to tell my patients that life is like a country song. You know, your truck breaks down, your dog runs away, your partner leaves you, life happens. You end up relapsing and you pick yourself up and you start over at day one. So this is not a one and done type thing. It's something that people will deal with their entire lives. It's also not very black and white in terms of whether or not somebody has an addiction. There's different levels when you talk about use. Is it an occasional use? Is it something that they do once in a blue moon? Is it something they do with friends for recreation? Do they do it regularly in the sense that they're able to, you know, a couple times a week they'll use, however, it's not affecting their ability to go to work, pay their bills, care for their family, versus addiction, which the technical definition is that the use, the drive, and the acquisition is all factors that prevent you from holding down a job, paying your bills, those types of things. Just some quick background. We do know that it is related to the brain. That's what that picture is showing on the right, that the basal ganglia has been linked to addiction, so it is a neurologic issue. We do know that pharmacological treatments, and I have worked with some people in terms of that are giving medical alternative therapy, Suboxone, Subutex, as well as talk therapy, conversational therapy. And we know that these are important factors, both of them in conjunction, in terms of adequately treating the underlying addiction. And the final thing, and I hope this is a reminder for everybody and nothing more than that, is that addiction is a DSM-5 disorder. It is recognized within the psychiatric community as a medical condition. It is not because somebody is a poor character, lacks moral fiber, they don't have the motivation or the willpower, all these other tripe, really, that people say about why people use. It's a neurologic, chronic, relapsing condition that the patient will be dealing with most likely for their entire life. Next slide, please. So this patient comes in. They have hepatitis C, and they also have either a distant or a fairly recent history of substance use. How do you deal with that? And again, some of you may have been dealing this with regularly. Some of you may be a little more uncomfortable. So I'm going to kind of talk through how I approach these patients who have a history of substance use disorder. Next slide, please. So the first thing is rapport. Some pretty basic things that I do to keep in mind, rather, to strengthen a relationship is to recognize that when they come to you for hepatitis C treatment, they're coming to you voluntarily. They're not being forced to come. This is not something that's, you know, most likely they're being mandated to do. But because they're coming to you and saying, hey, I have hepatitis C, I want to get treatment, recognize that they're showing motivation on their part to do things to address their underlying medical issue, the hepatitis C. So they're motivated, they want care, they want help. So they're reaching out to you, so they are trying to meet you somewhere in the middle. The other thing to recognize is that if you ask these patients, you know, what have your previous experiences been? By and large, they're probably negative. They probably have dealt with healthcare providers that have looked down upon them, that have given them difficulty in terms of any sort of access to medical care. So they probably have very strong negative opinions of their previous exposure to medical providers. So that's going to be a barrier you might have to break down. You might have to work a little bit to show them that you're willing to work with them, that you want to help them, that you're not going to judge them. And at the same time, recognize, do you have any preconceived notions? I know I had to do a lot of thinking about what do I consider addiction and the typical patient and a person's social situation, whatever. There's a lot of baggage that you bring in as well. So this is a weighted relationship on both sides. You have baggage, they have baggage when it comes to drug use that you're both going to have to work through and or put aside to build a meaningful patient caregiver relationship. And then finally, are there any legal or law difficulties? As was mentioned previously, you know, some of these patients may have outstanding warrants, they may be going to jail. How is that going to affect their ability to receive care? I've spoken a couple different times, you know, patients who are on Epclusa or Harvoni and they end up having to go to prison. Are they going to be able to get their medication there? So these are things that you have to know in terms of how it's going to complicate their ability to get care, their ability to follow up, their ability to be present. So it is something that you need to know when determining what the care plan is going to be. Next slide, please. So some of the other things I do is recognizing, you know, it's important to have boundaries. And certainly that stands for any patient that you have, what you will or won't do. But I tend to be very blunt and upfront and kind of outline what my boundaries are to the patient when they come in. So if a patient is coming in to receive care, you're going to treat them for their hepatitis C. Tell them what your role is, what you're going to do, what you're not going to do. Are you going to be giving them medical alternative therapy? Are you going to be giving Suboxone or not? Are you going to be able to refer them to someplace that can? What is your policy on pain medication? Some of these people might have gotten into substance use issues because they have chronic pain, so they had to go to the streets to use whatever they can. So pain might be an issue. Are you going to provide that or are you not? And if not, are you going to be providing referrals for that patient to go somewhere? The other thing that I think is important to recognize that I'm sure John has spoken at length, because I'm very much stealing this from him, is the idea is this is a long-term disease. This is not something that most likely, if the patient is stable, this isn't going to be where they wake up tomorrow and they have, you know, full-blown fulminant hepatitis C. This is something that can take some time. So it's not necessary to hammer out that day starting somebody on their Epclusa. This is something that you can work out a timeline, figure out how to best approach it with you and the patient, both coming up with a plan moving ahead, and kind of reassure them. Most patients don't know until they come in that they have hepatitis C, so they might be unaware of what the prognosis is. So reassuring them that it's typically slow and it could take 10, 20 years before there's any change in, you know, any of their markers. So that type of reassurance can also be beneficial. And then, as I said, is now the time to treat the patient. If they are actively using, is it appropriate to treat them now? You know, whether or not you feel it's appropriate or the insurance feels it's appropriate. How can you help them overcome that barrier? If they are currently in remission, what's the risk of relapse? Is that a factor that has to be appropriate for determining the onset of treatment? And then, as I discussed before, is it appropriate to start treatment when somebody is expected to do some time incarcerated where they won't have access to their medications? So the timeline and the boundaries are really important when you're talking to the patient. You're involving them in the decision-making process. You're getting them involved. They're buying into the plan. And that should help you feel reassured that they're committed to this process of getting their hepatitis C treated. Next slide, please. As I said before, it's a two-way street. Not only do you have to prepare them, but you have to prepare yourself. As I mentioned, you are providing care to people in your community. So these are people that are around town that you're typically seeing in small underserved areas. So that is typically something that helps me get up out of bed every morning to realize that, you know, I'm helping people who really don't have the means to help otherwise. So I'm willing to bet most of you have already kind of committed to that, but it might be something else to consider when you're talking about a population that has issues with substance use. So recognizing that they probably have nowhere else to turn to. The other thing to keep in mind is that you are treating a highly infectious disease. This is something that, in my opinion, by treating one patient, you're able to prevent others, especially in terms of substance use disorder. So if you have somebody who is a user, And in my opinion, if they're actively using, by treating them, you're preventing other people from getting infected. But certainly you're able to control, no matter how you look at it, the spread of further infectious disease. And then additionally, you're also encouraging the patient to become healthy. You're helping them treat a chronic issue. And then by treating this hepatitis C, that may help with the process of their substance use disorder. So they're able to show that they can take a pill, 3 pills a day for 8 weeks. So maybe that means they can actually go through substance use therapy and get on to Suboxone, or to go cold turkey off of everything. So there's a lot of benefits in terms of substance use disorder you can bring about in a patient by treating their hepatitis C. Next slide, please. So when I talk about comprehensive care, and again, this is very much on the front lines of any general practitioner, internal medicine, family medicine, what have you. But these are a couple things that I keep in the back of my mind when I'm dealing with this population to provide comprehensive care. Next slide. Next slide, please. So the things that I typically think about are, what other infectious diseases do they have? Because if they have hepatitis C, certainly there could be other things that they have contracted through their risky behaviors. Are they up to date on their immunizations? Talk a little bit about substance use disorder treatment and therapy, and then the follow-up. Next slide, please. So other infectious disease, I think HIV is probably on the top of everybody's mind. That's usually checked kind of as a reflex with anybody who has a history of substance use or injection use. But the other ones I think about are sexually transmitted infections. Again, this is a population that has a propensity for risky behaviors. So risky sexual activities is certainly one of those things. So I typically screen for syphilis, gonorrhea, and chlamydia. The other one is, this is typically what I see, as I said, in the hospital: endocarditis, infection of the heart valve and surrounding tissue, osteomyelitis, bone infections, and septic joint infections. Typically, if a patient has this is going to be pretty obvious. They have a big red swollen joint, or they have a pain out of proportion, but they may be asymptomatic. These are usually slow burning and take a while to present themselves. So recognizing that they may have a serious underlying infection when you're doing the initial workup is something to keep at least in the back of your mind. And to recognize that they have other hepatitis infections. Certainly there could be co-infection with hepatitis A and hepatitis B. Hepatitis B we usually give a lot of talk to in regards to, can there be reactivation with hepatitis C treatment? But hepatitis A is pretty prominent within the population of IV drug users, especially in West Virginia. So it's something else to keep in your mind. Next slide, please. And that leads me right into immunizations, which bless every one of you who's able to do this, because it definitely makes a big difference. So for immunizations, obviously you want to make sure they're up to date. If they've gone to public school in West Virginia, then they've had their basic ones. But the ones to keep in mind is to press upon them to get a yearly flu shot. Make sure that their Tdap shot is up to date, has it been within the last 10 years. And then, as I mentioned in the last slide, hepatitis A and B vaccines. And again, it seems like a pretty minor thing, but in my opinion, having somebody who is up to date on their vaccinations can really be beneficial long-term for the patient's health. Next slide, please. And then finally, we get into the substance use disorder treatment. And I think it's very appropriate whenever you're talking to a patient and discussing their history with substance use. What is their plan? How are they going to receive treatment, or what are they going to do? And the first thing I want to point out is that in treating infections, it's very easy. Hepatitis C, there's a couple caveats you need to know. What is the genotype? How far along have they progressed? Have they failed other medications? But by and large, with infections, if you know the bug, if you know the etiology, you just have a couple choices. When it comes to substance use disorder treatment, every patient is different. Some respond well to good Suboxone, some don't. Some require intensive therapy. Others just need group, therapy. Everybody's a little different. So I caution you against being very rigid in terms of, well, I will only treat you if you're on Suboxone or something to that effect. So just recognize that everybody has a very different approach as well as outcome when it comes to treatments. And I have some different ones listed there. Again, these are all things that different people respond to differently, so keep it in mind. And the other one, of course, is alcohol abuse. Obviously, we're dealing with a disease that greatly affects the liver. So recognizing whether or not they have or had a history of alcohol abuse is something to keep in your mind whenever talking to them about substance use, because it's not just pills and it's not just heroin, but it can also be alcohol. Next slide, please. So to briefly get into medical assisted treatment, the one that you're most commonly going to hear is about something with buprenorphine. If it's buprenorphine alone, that's Subutex. You can also get that as an injection, which is Subucade. I know at West Virginia we don't offer it. It's still fairly new on the market, but a lot of patients have been asking for it. It's essentially, as it says there, once a month, they get the injection of the Subucade, and they don't have to worry about taking strips every day. Another one would be naltrexone oral, or a monthly injection. Same idea, once a month they come in. The naltrexone is the agonist, which if somebody was to take an opioid while on that, they would become ill. The other thing that we have found is that naltrexone actually does affect somebody's impulse, that's a craving to use. So even if they don't have a anti-abuse type reaction to it, we've found that using Vivitrol or even the daily dose can very much inhibit somebody's desire or cravings. And then Suboxone is when you combine the two, the buprenorphine and the naloxone. As I mentioned, the buprenorphine is the agonist, whereas the naloxone is the opioid antagonist. The idea behind medical assisted treatment, it's a little different than, in my opinion, what methadone is, in the sense that we don't use Suboxone, for instance, to get somebody high or something to that effect. It's to make somebody feel normal. And if you've ever had a conversation with somebody who's being appropriately managed on Suboxone, that's exactly what they'll tell you, is that, they don't feel good, they don't feel great, they feel normal, they feel like they can go about their day without having to worry about where they're going to get their next hit. So that's really the goal, is that you're preventing withdrawal and cravings, but at the same time, when you have the naltrexone present, you're able to prevent any misuse or abuse. And the good news is that if you can get people on buprenorphine, and if you can keep them on that for a year, over 3/4 of them will maintain that sobriety. Next slide, please. So when somebody says they do want substance use disorder therapy, how do you respond? Like I said, not everybody is comfortable doing that. I myself got an X license, so I am able to give Suboxone to my patients, but I recognize not everybody wants that burden or feels comfortable doing that. So I recommend that you know who does, whether it's somebody else in your practice or locally, who can provide either the Suboxone or individual group therapy. The one thing I'll point out is, because a lot of our patients are on subsidized health insurance, such as Medicaid, if there is a behavioral therapy component to a clinic you send them to, they will provide assistance, both financially as well as in terms of transportation. So that's something to keep in the back of your mind. The other thing is that, again, I'm not starry-eyed about this. I know people slip up, and I know people are going to reuse. So if you do have a serious conversation with your patient, remind them that even though they've been treated, certainly by going back to using, it's like pregnancy. It takes one time and you can be reinfected, and it can be a new strain, or they can get something more severe like HIV. So talk to them about needle exchange programs, not to share any of their kit or supplies with anybody else who is present. Next slide, please. This is actually a advert I found from the CDC. It's about a little over 2 years old at this time. I guess they have more important things on their docket than clean syringes at the moment. But this is actually something that they recommend as a kind of a last-ditch effort to clean your own syringes. Again, I think West Virginia is getting better about clean needle exchanges, and certainly there are websites which have those listed. But just be aware that there are always alternatives to sharing any needle. Next slide, please. I'm not going to go through this. This is on the, again, this is just showing that on the website there are different resources that are available to you in terms of getting people tapped into Narcotics Anonymous, as well as the needle exchange. Next slide, please. And again, this is that probably at least crosses your mind once or twice, is that, you know, this is a population that a lot of us as peers are a little unfamiliar with, in the sense that it's a younger population. We deal with an older population in terms of medical issues, hypertension, diabetes, but recognize that this is a population that is much younger. And we probably see them as being kind of unmotivated, unreliable, to be very broad in terms. But as I pointed out very early, they are here to get help. They are here to voluntarily, and they want the medication. So they are very motivated. Oh, I lost my screen again. Don't know why it keeps doing that.
Are you able to see that okay now?
Yeah, I can see that. Sorry about that, everybody.
No worries.
Yeah, so building rapport is important, to remind them that you're there for them. It'll help them buy into the process, not only for the hepatitis C, but hopefully for their substance use disorder. And then usually on that first episode, that first encounter, they're obviously there for the hepatitis C, and that's what you should focus on. But I recommend kind of framing it in the sense that this is because of their substance use disorder, and you want to be able to address as much as you can. Next slide, please. So to kind of wrap everything up, as I said, and as we're all very well aware, hepatitis C, it's been increasing exponentially throughout the country, especially here in West Virginia, and that this increase is directly correlated with substance use disorder, specifically with intravenous use. As I said, West Virginia is highly affected by this. Please remember that addiction is a chronic relapsing disorder. It's recognized by the DSM-5, and that it is not simply because they're not motivated. These patients have come to you voluntarily, but despite them coming in of their own free will, they probably have a lot of baggage. So that is something where we all have to kind of work to overcome. I recommend strongly you be very upfront with your patients in terms of what your expectations are to provide care and for them to receive medication, as well as what they expect in terms of your treatment as their physician or your care provider, their care provider. Recognize that treating the hepatitis C can help the patient, not only because of their hepatitis C infection, but with their underlying substance use disorder, and you're also preventing further spread of hepatitis C. Practice comprehensive care of the patients. Look for sexually transmitted infections, HIV, or other viral hepatitis infections. Immunize, please vaccinate them, use them as pincushions. I do recommend you talk to them about what their plan is for substance use disorder treatment, and have at hand some options that they're able to follow up on. And then really work with them to make sure they buy into the process, buy into the plan, and get some firm follow-up in place before you go much further. Next slide, I think that's it. Yep, that's it. So again, it's a unique population. They come with their own unique trials, tribulations, and obstacles to overcome. But as this is the population we are seeing nowadays with hepatitis C, that's why I think it's important to kind of understand this is a different group, a different beast, so to speak, that we all have to deal with. So we're right at 1:15. I'm happy to answer questions now. If there aren't, or if there's questions that come up later, certainly I will be available by email. If somebody wants to reach out, I'm more than happy to do so. But by all means, I open the floor now for any questions. Thank you very much for your attention, though.
Awesome. Thank you so much, Dr. Cooper. Yeah, we are at the end of the session hour, but if there are any questions or comments for Dr. Cooper right now, just feel free to ask away.
Hey, Garrett, this is John. I just wanted to, Garrett, Dr. Cooper is certainly one of the most experienced ID doctors working with addicted patients. And I want to just thank you for lending your expertise and overview of how you approach these patients. Always learn. Thank you, man.
Yeah, that's excellent. We're getting a lot of thank yous in the chat as well. So All right, well, if there are some questions after the fact, just feel free to shoot me an email. I can make sure to send them over to Dr. Cooper and have them addressed and sent back to you all. Before we part ways, I just have a couple housekeeping announcements. So our next session will be on September 24th, and Dr. Gilfus will be discussing when HCV treatment is deferred. So keep an eye out for that reminder. I think Dr. Bailey and Jenna had to hop off, but I wanted to thank them as well for the case. And thank you so much, Dr. Cooper, for that awesome didactic. We'll see you all next time. Thank you.